Is our vital sign, pain management, sleep, and comfort. For vital signs, you are recording and reporting them on your CNA flow sheet. So it is your responsibility to record vital signs, and you're recording them on the CNA flow sheet. It's the same usually it's the same sheet that you're doing your ADLs on, or your activities of daily living, how they ambulated, how they toileted, how they ate, how they showered, how they had personal hygiene, and there's a section on there for vital signs as well. Vital signs are usually routine reporting. They'll tell you when you work, we want you to come in on day shift and have your vital signs on the chart by 10 a.m. So it's just up to you to get your vital signs and get them on the chart. But if you get an abnormal vital sign, you have to report it stat or immediately. Okay, so don't just write it on the chart if you know it's abnormal. Let the nurse know and then write it on your chart. You're recording your vital signs as temperature, pulse, and respiration. So you have to know what these normals are in order to be able to report the abnormals to the nurse immediately. You don't have to know how to convert Celsius to Fahrenheit when you're doing temperature. There's conversions on your phone, or you can look at it on a chart. Some places you work are going to want it in Fahrenheit. Some places want it in Celsius. But just know that 98.6 is ideally normal Fahrenheit, and 98.6 is the same as 37.0 Celsius. So always record the site that it was taken. If you have a green or blue dot thermometer, it's going to be an oral thermometer, or PO. So that's one that you're going to put in their mouth. It's blue or green colored. There's no eating, drinking, chewing gum, smoking within 15 to 20 minutes of taking a PO temperature. If you go in and the person is eating or just had something to drink, you need to wait 15 to 20 minutes, or you need to take the temperature axillary or tympanic or some other way. Normal oral temperature is 97.6 to 99.6. Anything outside those ranges, you're going to report as stat reporting. A rectal temperature is going to be taken with a thermometer that has a red top or a red label on it. That's the most accurate. So what you need to know for rectal temperatures is they are the most accurate, and so they're going to be a little bit higher. If you have a temperature of 98.6, which is ideal, to 100.6, that's normal for a rectal temperature. You're going to see a video on rectal temperatures, and you're normally only going to take a rectal temperature on a very small infant. Sometimes you'll take it on an adult that's comatose. But usually it is the most accurate, but we don't take it very often. Your axillary temperature is one that's underneath your arm. This is one that you have to make sure that when you take an axillary temperature, you write what you read, or you write what it says, and you write AX after it so that we know that it was done axillary. It's usually a degree lower than a PO temperature, but you don't automatically add that degree. You write what it read and you write AX. Axillary means skin contact, so you have to actually stick it in their armpit against their skin. You can't just put it on their clothes or put it on top of their shirt or gown. It is the least accurate, but it can be less, so it'll be 96.6 to 98.6. And then tympanic is one that you're going to get in your ear. A lot of places now have these tympanic temperatures. That tympanic is almost as accurate as rectal. And as long as you really get it into their eardrum, in their ear canal, then it will be accurate. And it's going to range from 98.6 to 100.6. It's best for the confused residents and for the children. And we have a little tympanic one that y'all can practice doing on each other. And the video is going to show you when you do a tympanic temperature, you pull up on their earlobe. And when you pull up, stick it in and press the button. Okay? It actually has to go into the ear canal because you're trying to get it on the tympanic membrane, which is inside the ear canal. If you're getting a child or an infant, you pull down on their earlobe and stick it in. And it's just the difference in the way that the eustachian tubes are pointing. So, glass thermometers are rarely used anymore, but we are going to learn how to use a glass thermometer. There is danger of mercury. If you drop it, it needs to be picked up with a broom or dustpan, and the mercury will spread all over the floor. It's hazardous, so don't touch it with your hands. It's cancerous too. But mostly now we don't have these glass thermometers anymore. we have the electronic thermometers. If you do work for a place that has the glass thermometers, or if you have a patient on isolation, they're going to have their own separate equipment in there that doesn't come out of the room. It stays in there with them, and it may be a glass thermometer. That's why we have to learn how to use and read the glass thermometers. The glass thermometers, each one of the little small notches is a 0.2. And you can see the big numbers are labeled, so it would be like 96, and it has Fahrenheit on the top and Celsius on the bottom. But 96.2, 96.4, 0.6, 0.8, and then 97. And then it goes up from there. It has in red the 98.6, which is your ideal. Okay. And then the electronic thermometers, when you're using them, when you pull the probe out of its sheath, or out of the machine, you have to stick the probe cover on it and then stick it in the person's mouth. If you take too long pulling it out from the machine, putting on the probe cover, the machine will cut itself off. You have to take the probe cover off, stick it back in the machine to reset it to turn it back on again. Okay. This is a video on how to take a temperature.
Normal body temperature varies from client to client, but is generally below 100 degrees Fahrenheit. If the body temperature rises above 100 degrees orally, the client is said to be febrile or have a fever. If the client's temperature is in the normal range, the client is said to be afebrile. Fever is a sign of disease, not a disease in itself. It indicates that the body is reacting to an infection. In addition to fever, the client's temperature may rise due to exercise, being outside in warm weather, or wearing too many clothes. Body temperature can be measured in several ways. An oral temperature is taken in the mouth. An axillary temperature is taken in the armpit. A tympanic temperature is taken in the ear. And a rectal temperature is taken in the rectum. When recording a client's temperature, make sure you indicate where it was taken. Write 99.8 R or 98.6 A. A client's temperature may be measured using the Celsius or Fahrenheit scales. Digital thermometers are the best for taking temperatures. They are inexpensive, easy to use, and provide accurate readings. The ranges for normal body temperature depend on the site. For oral temperatures, normal body temperature is between 97.6 and 99.6 degrees Fahrenheit. For axillary temperatures, normal body temperature is between 96.6 and 98.6 degrees Fahrenheit. And for rectal or tympanic temperatures, normal body temperature is between 98.6 and 100.6 degrees Fahrenheit. To take a tympanic temperature, you will need a tympanic or ear thermometer and a disposable probe. Follow your agency policy as to whether you should wear gloves when taking a client's tympanic temperature. Wash your hands and tell the client what you are going to do. Place a new probe cover on the thermometer. Turn the thermometer on. Insert the thermometer into the client's ear. For an adult, pull the top of the ear up and back. For a child under 2, pull the earlobe down and back and gently insert the probe in the ear. Press the top button as you insert the probe. Then listen for a beep, which will only take a few seconds. The beep indicates that the temperature has been taken. Remove the probe from the ear. Read the temperature. Record it right away so you don't forget it. Wash your hands. Rectal temperatures may be taken for infants and small children. For this procedure, you will need a digital thermometer, a disposable cover, disposable gloves, a water-soluble lubricant, and an alcohol wipe. Wash your hands and apply the gloves. Tell the client what you plan to do. Place the plastic cover on the thermometer and lubricate the tip with a water-soluble jelly. Do not use petroleum jelly. Position infants on their abdomen and adult clients on their side. Do not expose them any more than necessary. Gently insert the tip of the thermometer into the rectum, no more than ½ inch. Hold the thermometer in place and wait for the beep. Then remove the thermometer. Dispose of the plastic cover and wipe the tip with the alcohol wipe. Remove your gloves and wash your hands. Record the temperature. To take an oral temperature, you will need a digital thermometer, a disposable probe cover or sheath, and disposable gloves. Wash your hands, apply the gloves, and tell the client what you are about to do. Apply the probe cover or plastic sheath to the tip of the thermometer. Place the probe tip well under the tongue. Turn the thermometer on. Ask the client to close their mouth and wait 10 to 20 seconds. Listen for the beep and remove the thermometer. Read and record the temperature. Then remove and discard the disposable probe cover. Turn the thermometer off, remove your gloves, and wash your hands.
So the video says to record your temperature immediately, but you have to wash your hands before you record it in the chart. Okay. So if anytime you take your gloves off, you have to wash your hands immediately. Yeah. But you can write it down on a scrap piece of paper, or maybe on a like a napkin or something, or bring in a little your CNA assignment sheet and write it on there. But before you touch their chart and write it in their chart, you have to wash your hands. So for national testing, when you're doing vital signs, you have to get your vital sign, get everything, all your ending procedures, wash my hands, and then go record. So recording is the last thing that you're going to do. It also says children less than 2 for pulling down on their ear. And then there was one more thing that's kind of different in the video. I can't think of it right now.
Down and back.
Down and back for the infant, but pull up and to get in. Up and back. Now, that's the same thing when you're putting in a hearing aid. So when you're helping them put their hearing aid in, you pull up and stick their hearing aid in. You pull down to get the hearing aid out. Okay. All right. And we're going to do your temperatures. We'll work on those in a little bit. But remember that the tympanic is for confused residents, and you'll be using that a lot in clinical now. Your vital signs. So, taking your pulse, we have to count for 1 full minute. Oh, that was another thing. With the temperature, with the some facilities, per facility policy, want you to wear gloves when you're taking a temperature. Some places don't want you to wear gloves. So it's just a per facility policy if you're going to wear gloves when you're taking temperature. When you're taking someone's pulse, as long as they're not on isolation, you're not going to wear gloves. Okay? But you're going to feel for their radial pulse, which is the one right here on their wrist. Okay? You have to count for 1 full minute. Some facilities let you count for 30 seconds, multiply it by 2 to get your full minute. But that's only if they have a regular pulse. If they have an irregular pulse like atrial fibrillation, or if they have skipped beats, or if their heart speeds up and then slows down and speeds up and then slows down, you need to count it for 1 full minute. Okay. Normal adult is 60 to 100 beats per minute. Anything less than 60, you're going to report. A lot of times, some of the adults are going to need a pacemaker or a defibrillator implanted. Anything above 100, they could be in atrial fibrillation, or they could be in VTAC, or they could be in some kind of heart condition where they need to be reported. So less than 60, greater than 100, report it immediately. If they also have a weak and thready pulse that you can barely feel, then you need to report it immediately. Normal child pulse, children have higher pulses until they hit puberty. So if you're going home and you're practicing on your kids, it's okay if their pulse is 120. or 130, as long as they haven't hit puberty yet. Okay. So usually a child's pulse is between 70 and 190. For an infant, if their pulse gets less than 60, you do CPR on them. Even if you can feel their pulse, if it's less than 60, they need CPR because the infants have really high pulse rates that need to be in the 90s to 100s. So, report any abnormal pulses, any skipped beats. If it's too faint and you can barely feel it, you need to let the nurse know. So don't just guess or don't just put down a number. You have to make sure the pulse is their heart beating. And if their heart is not beating properly, we need to know. That's going to be a medical emergency. There are several different places where you can take a pulse, and you don't necessarily have to know all of these places. The apical pulse is one that we're going to auscultate or hear. So the nurse would actually listen to that pulse with her stethoscope, and you're going to feel the brachial pulse while the radial pulse while she's listening, and we're trying to see if the person has any blockages from what the heart is actually pumping to what it's getting out to the periphery. That's the apical radial deficit that sometimes we ask you. I'll listen to it while you take it, and we'll see if we come up with the same number. My heartbeat that I'm listening to will be the most accurate number. What you're feeling will be less than what I hear sometimes. That's how we know people have blockages in their arteries. So the brachial pulse is what we do for infants. And the brachial pulse is right here in their arm, the upper arm. When you're doing the CPR video, we'll take an infant or baby's pulse right here in their arm. The carotid pulse is one on your neck. When you're doing CPR, they want you to check your carotid pulse. It's easy to feel. It's on both sides of your neck, but you should take less than 10 seconds trying to find the pulse on the side of their neck. If they can't feel a pulse beating on the side of your neck, then just give them CPR. Your dorsalis pedis pulse, your posterior tibial pulses are on your feet. When you're putting on your stockings or your TED hose or your compression stockings, we need to make sure they still have a pulse in their feet. So we feel for those, and that's why those stockings have a hole in the top of them, so we can just peel them down and feel for the pulse. Your popliteal pulse is behind your knee. Your femoral pulse is in the groin of your leg. Sometimes if you work in a hospital, your patient's going for a cardiac cath, you may have to shave their groin, because the doctors are going in the groin area to the arteries and veins that are in their groin. But you can feel a popliteal pulse pretty well in your groin. Or your femoral pulse, sorry. Popliteal is behind your knee, femoral is in your groin. But what we're going to do is do our radial pulse. It's always on the thumb side of the wrist, and it's kind of about 2 fingers down from the bend of your wrist, and you'll feel a little groove. And you'll be able to feel the pulse. You're going to feel it with 2 or 3 of your fingers. Don't feel it with your thumb, because if you put your thumb on there, you'll feel your own pulse. So it's running through the thumb side, and you're using 2 or 3 fingers to feel for the pulse and counting for 1 full minute.
The rhythm of the pulse is an indication of how regularly the heart is beating. The rhythm of the pulse should always be regular, with no beats that are skipped, missed, or that come early in the cycle. Perform your beginning procedure actions. You will need a watch with a second hand, notepad, and a pen. Locate the radial pulse on the thumb side of the wrist. Place the first 3 fingers of your hand on it. Look at your watch and count the number of pulse beats in 30 seconds. If the resident's pulse is irregular, count for a full minute. Multiply the number of beats in the 30-second period by 2. This gives you the number of beats per minute. Record this number on your notepad. Remember this number if you are also counting respirations. If you will be checking the resident's respiratory rate, leave your fingers in place. If not, now is the time for procedure completion actions.
Okay, so the next video is going to be me taking the pulse. So beginning procedures, taking the pulse, and then ending procedures, just like you'll need to do for your national testing.
Come in.
Hello, Mr. Mills. My name is Tanya. I'm going to be your CNA today. It's time to get some vital signs. We're going to start with counting your radial pulse. For this, we're going to be a watch or the clock on the wall with the second hand. I need to wash my hands, practice the courtesy, and get your bed to a comfortable position for myself. Low. And with 2 or 3 fingers, raise both sides of your arm, which is just on the side. Yeah.
So you need to tell the tester when you're starting.
Make sure not to be looking at the clock. If I do lose your pulse for any reason, I can stop at any time. They run 70 to 190, and that would still be normal. For athletes or people with well-conditioned hearts, their heart rate can be in the 50s, and that would still be considered. For 1 full minute. We're also going to report in 60 to the nurse immediately. Okay, thank you. You're done. There's your call bell. I'm going to coming over to the pen and recording each part after I wash my hands and write our results and candidate results, measuring and recording your pulse.
Four beats of the tester. He's going to be testing on the other arm. People should have the same pulse in both arms unless they have a blockage in one, but it's usually not off by more than 4. Okay. But if you lose it, you don't have to wait for that minute to finish. As soon as you lose it, you say, oh, stop, we're going to start over. But every time you start, you tell him, okay, we're starting, and then when you're done with your minute, you say stop. And then record the pulse that you got. Counting for 1 full minute after you wash your hands. All right, respirations is the next one. So when in real life, you're not supposed to be telling people you're taking their respirations. When you tell someone you're watching for the respirations, they stop breathing, or they hold their breath, or they start talking. So you are just holding your fingers on their wrists like you're still taking their pulse and take their respirations. Some facilities let you count respirations for 30 seconds, multiply it by 2, and that gives you your full minute. For national testing purposes, you're going to count respirations for 1 full minute. And you're only going to do one or the other. You're not going to take their pulse and their respirations. But when we're going to come in, you're going to tell them you're taking their respirations. Okay? So you don't have to hold their wrist. You just need to sit by them. And then you as the partner, make sure you're breathing. Close your eyes. Don't think about them staring at you. Don't laugh. Don't talk. But just breathe normal. Normal respirations for adults is going to be between 12 and 20. When y'all start doing each other, you'll see sometimes people are only 10, which is fine for us because we're breathing and our pulse oxes are fine. But in real life, if you're at the facilities and someone is breathing 10, you need to let the nurse know. Okay? So anything less than 12 or greater than 20 needs to be reported stat. For children, again, they breathe a little bit higher. They're going to be 16 to 35, and they're going to be fine. But if you have an adult breathing 35 times a minute, there's something wrong with them. Okay? Abnormal breathing patterns, if it's really shallow, if their chest is barely moving, if it's labored and it looks like they're using all these accessory muscles to draw air in, or if it's rapid and really fast and shallow, you need to let us know. Cheyenne-Stokes respirations are abnormal respirations when people are starting to pass away or when they're in the process of death and dying. They start breathing irregularly. They may take a big gasp and then they'll stop breathing for 20 seconds and then they'll breathe rapidly and shallow and then their chest will barely move but they're still like panting and then they'll stop breathing and then they'll take one big sigh. And those kind of respirations, you need to let the nurse know immediately. Anytime you see someone having difficulty breathing, the dyspnea, difficulty breathing or painful breathing, they need to make sure they're sitting up. We already saw this in the last chapters when we talked about COPD and emphysema and even asthma in the children. It's hard to breathe when you're laying flat. A lot of these people need to be sitting up. They sleep in a recliner. They sleep with their head elevated. If you lay them flat on their backs through time, they stop breathing. Okay, so anytime you have someone having difficulty breathing or dyspnea, make sure you raise the head of the bed, pull them up in the bed, lean them over a table, sit them up. Definitely, if anybody's having apnea or absence of breathing, you need to let us know. Some people have apnea when they sleep at night. They sleep with that CPAP or BiPAP machine that we looked at. Those people know how to put the masks on. The machine is already preset. There's nothing you can change on the settings for it. All you do is put the mask on them and press the start button. Okay.
With your hand still at the resident's wrist, glance at his or her chest while continuing to look at your watch. Respiration is under voluntary control. For this reason, the resident should not be aware that you are counting the respirations. Count one inhalation and one exhalation as one respiration. Multiply the number of respirations in the 30-second period by 2 to give you the number of respirations per minute. If the respirations are slow, rapid, or irregular, count for 1 full minute. Record the resident's pulse and respiratory rate on your notepad. When you have accurately recorded your findings, perform your procedure completion actions. Report any significant changes to the nurse. One normal respiration is counted as one inhalation and one exhalation. They should be smooth, regular, and unlabored. Normal respiratory rate for adults is about 14 to 20 per minute. Report any rate below or above the normal range.
Come in.
Hello, everyone. My name is Tanya. I'm going to be your CNA today. I'm going to get your vital signs on here. We're going to do your respiration first. The supplies I need for this are going to be my watch with the second hand and a recording pen and paper. Watch the clock on the wall with the pull your privacy curtain. Have a seat next to you. Make sure for testing purposes, we are going to tell you that we are counting your respirations, but I'm going to just expose your chest so that I can see your chest rising and falling. Each expiration is going to fall, and count for 1 full minute. Start. So each inspiration. We're going to make sure to raise your head in high tower position, or have you sit up straight and lean over top of your bedside table. Counting for 1 full minute. Stop. I'm going to cover you back up. Make sure that you're fall down. Respirations. Normal respirations are going to be between 12 and 20 for an adult. Thank you. Have a nice
Okay, so even if you just say, wash my hands again, before you pick up that pen, just say, wash my hands, and then you're going to record on their chart. Just put your result. And counting for 1 full minute for pulse, or counting for 1 full minute for your respiration. Okay. But on the written part of the test, it says if you have a regular pulse or regular respirations, some places will let you count for 30 seconds and multiply by 2. Your pulse ox is the measure of your oxygen saturation. A lot of times now the nurses are getting the pulse ox. It's a little portable machine they carry around, but sometimes they will ask you to get it. Whenever you have a person having dyspnea or apnea or turning cyanotic or blue, we need to get their pulse ox. If they have on fingernail polish, it may not read through the fingernail polish so well, so we need to get the fingernail polish off, or we need to put it on their earlobe or their toes. If their fingers and toes are really cold and they're not getting really good circulation, sometimes it won't read either. But it's measuring how much hemoglobin is circulating around our body and carrying oxygen to our cells. Normal pulse ox is going to be 95 to 98 or all the way up to 100. It's 95 to 100%, but 95 to 98 is normal. Okay, if it's less than 95%, we're suspecting that something is going wrong with them. They either need to sit up straight and deep breathe and cough, or they need to have some supplemental oxygen put on once we get below 90. But usually if you're taking it and you first get it and it says 80, tell your person to sit up, take a deep breath, cough some, use their incentive spirometer machine to open up their lungs to get their oxygen saturation higher. The next one is you don't have to do oxygen saturation for national testing. We're going to do it for each other and learn how, but just make sure you know to take off nail polish or use it on their earlobe. Your blood pressure for your vital signs, blood pressure. So your systolic number is the top number. It's the pressure of the heart at work. It's when your heart is pumping. This is going to be the higher number. Ideally, they keep changing all the guidelines on blood pressure. They just updated it again for 2017, but you're going to go with these guidelines that we know for the CNA testing. Ideal blood pressure, systolic number, is you want to be less than 120 on the systolic number. Now, in 2017, it says as long as you're less than 130, you're fine. Okay. But normal blood pressure is going to be between 90 to 140 on the systolic number. If you get someone's blood pressure and their top number is less than 90, you need to let someone know. If the top number is greater than 140, you need to let us know. They had some guidelines in 2013 that said for elderly patients, as long as their blood pressure was less than 150 on the top number, it was fine. But now they've lowered it to everybody needs to be less than 130 on the top number. But we're sticking with anything below 90 or above 140, report it to the nurse. Diastolic is your bottom number, pressure of the heart at rest. So your heart is a pump, it's a muscle. It pumps and then it rests while it refills back up with blood. While it's resting, there should be less pressure in there, and it should be between 60 and 90. So if you get a bottom number less than 60 or greater than 90, let the nurse know. Both of the numbers don't have to be off. They're independent of each other. So if it's less than 60 or 90 on the bottom or greater or less than 90 over 140 on the top, let somebody know. But an ideal overall blood pressure was 120 over 80. Now it's 130 over 80. So if your blood pressure is 130 over 80 or less, then you're okay. But if it's above 130 over 80, you need to get it looked at. Blood pressure is a silent killer. It causes heart attacks and strokes. It makes your heart work harder, can put you in congestive heart failure, can make you have a stroke. Blood pressure just really needs to be controlled. Some people can control blood pressure with diet and exercise and losing weight and less sodium. Most people need medications to help them with their blood pressure. We take a blood pressure and put it on the chart before we give them a medicine for it. So if we're giving medications and you didn't tell us the blood pressure was already 90 over 40, and we give them a blood pressure medicine, it's going to bottom them out. Then they're going to get dizzy and lightheaded and hypotensive and pass out. So hypertension is if it's too high, they still are going to have maybe a headache or dizziness. And then they're going to have heart attacks and strokes, which could cause them to pass out. If it's hypotension, less than 90/60, it's too low, it's going to lead to fainting, and that's where we get a lot of the orthostatic hypotension. It's fine when they're laying down, but when they sit up or stand up, the blood pressure drops, they get dizzy, lightheaded, and pass out on you.
The blood pressure is a measurement of how the heart is working. It measures the force of the blood through the arteries. Perform your beginning procedure actions, which includes gathering the following supplies: sphygmomanometer, stethoscope, alcohol sponges, notepad, pen, and a plastic bag or container for trash. Wipe the earpieces and diaphragm of your stethoscope with an alcohol sponge. The cuff must fit the resident correctly, or the reading will not be accurate. Cuffs come in many different sizes. While most residents will require a standard size cuff, you will encounter those who will need an extra large or pediatric size cuff. The rubber bladder of the cuff should be at least 80% of the circumference of the arm. Locate the brachial artery on the thumb side of the resident's inner upper arm in the bend of the elbow. Wrap the cuff around the arm, centering the bladder over the brachial artery. The cuff should be 1 inch above the area of the elbow, called the antecubital space. Locate the radial pulse on the thumb side of the wrist. Keep your fingers there. Close the screw on the handset and inflate until you can no longer feel the radial pulse. Mentally note the reading on the gauge and add 30 to this. This will determine how high you pump the cuff when you check the blood pressure. Open the screw and deflate the cuff. After cuff is deflated, wait 30 seconds. Place the stethoscope in your ears and the diaphragm of the stethoscope over the resident's brachial artery. Close the screw and inflate the cuff to 30 points higher than where the radial pulse was last palpated. Slowly release the screw so the pressure in the cuff falls in 2 millimeters of mercury increments. Listen for the onset of a beat. When you hear it, note the closest number on the gauge. This is the resident's systolic pressure. Continue deflating the cuff until the beats stop. Note the closest number on the gauge. This is the resident's diastolic pressure. Continue to listen for 10 to 20 millimeters of mercury below the last beat to ensure you have the correct diastolic pressure. Open the thumb screw completely and deflate the cuff. Remove the stethoscope from your ears and the cuff from the resident's arm. Record your findings on your notepad. If you are unsure about the blood pressure, wait for 1 to 2 minutes and check again. Clean your stethoscope after each use by wiping the earpieces and diaphragm with an alcohol sponge. Perform your procedure completion actions. Report any significant changes to the nurse. In adults, the normal blood pressure range is between 100/60 and 140/90. Hypertension is the term used for high blood pressure. Hypotension is the term used for low blood pressure.
Okay, so that video shows you how to do it one way, but you don't have to do it like that for national testing. We're going to put the cuff on. You're going to feel for their brachial artery in the inner aspect of the bend of their arm. Okay. So, and it's really more, it's in the middle to the inner part of your arm. Okay, so as long as it's really coming towards the pinky side, not towards the thumb side. Your radial pulse is on your thumb side, but your brachial pulse comes up the middle and then into the pinky side. But you're gonna, where your arm bends is your antecubital space, and everybody can just, you can feel your own pulse. You can just find it in where the bend of the arm is, and then on the inner aspect. The bell diaphragm of your stethoscope is a big, huge circle. It's going to cover the majority of the area, even if you can't feel it so well. Okay. Just make sure that you're putting your cuff at least an inch above the bend of the arm, because when you put your big stethoscope diaphragm on there, you don't want it tucked up underneath the cuff, because it'll make noises and then you'll think that those are the sounds for the blood pressure. We're going to practice it a lot, but once you hear the thump, you're going to know what you're listening for. So you pump it up between 160 and 180. Nobody's blood pressure should be above 180 on the top number, okay? So 140 is the maximum. It says to pump it up 30 above where you heard the last. Now, people do have blood pressures higher than 140, but for class, you should all have your blood pressures normal. If not, you need to be on medicine before national testing. But, I mean, if it's normal as 140 to be high, then if we pump it between 160 and 180, then start to let it go down in increments of 2, you should hear it. And we're going to take each other's blood pressures and we'll know what our normals are and what normal people range. The same thing with athletic people, like with their heart rate is a little bit lower, sometimes their blood pressure is a little bit lower. If they're not normal, you need to be on medication so you don't have a stroke or heart attack while you're in class. But you will hear this first thump. And when you hear that distinctive thump, it's a rhythm. And you'll hear your thump, 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 thump. And then you'll stop hearing the thump. When you stop hearing the thump, it's the diastolic number. Okay? You can still hear a little bit of a rumble, 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 but you want that thump, thump, thump. Okay? Increments of 2 on your measurement. And you need to be within 8 points on the systolic number and 8 points on the diastolic number of what the tester gets as well. If you need to retake it, you have to wait 1 to 2 minutes to retake it on the same arm. Deflate your cuff all the way so the circulation can come back in their arm, and then wait 1 to 2 minutes and start over again. Okay. If you need to retake it for national testing, you don't have to wait your 1 to 2 minutes. You're just going to do it again or move it to the other arm and do it on the other arm. Okay? But if you don't hear it, deflate it all the way and start over again. Okay. This is how you do it for national testing.
Hello, Mr. My name is Tanya. I'm going to be your CNA for today. We're going to get some vital signs, and I'm going to get your blood pressure. The supplies that I'm going to need for this skill are going to be my dual-headed stethoscope, alcohol white, your stigma thermometer or blood pressure cuff that is the appropriate size for your arm, so that the bladder is within range, 10 on either side of the range here. So you are going to be using an adult large cuff. So wash my hands, pull your product next to your bed or in a comfortable position. Pieces and bell of my stethoscope with an alcohol wipe. Side is for the tester, so listen at the same time. After our stethoscope is clean, I'm going to expose the arm and your palm is facing upward, resting on your bed. I'm going to feel for your and then I'm going to place the cuff your artery. Going to make sure that we have your blood pressure cuff at least an inch above the end of your arm. Again with that bladder within the range area on the cuff. We're going to you can hold this for me. And on the bulb, we're going to make sure that it is closed or tightened. Lefty-loosey. I'm going to turn it all the way down. Stethoscope in our ears. And the other. to 160 to 180, and then deflate it slowly. If the sound occurs immediately upon deflating, to 200, and then start again. To 140. For the diastolic number, it's going to be 60 to 90. Anything outside of those ranges, you need to report to the nurse immediately. Put it in the slow to deflate. The first sound that we hear is your systolic at 120. At 70. And then after it gets past about 60 or 50, we're just going to deflate the cuff completely. To dispose of the trash and trash can, wash my hands, and then come over and record our findings. Measuring and recording your blood pressure, we're doing 120 over 70. Again, if it were over the 100 to 140, it would be considered hypertension.
Shut up, you fucking bitch. Shut up.
Alright, any questions about blood pressure?
No, I'm not.
So how do we walk in? You start explaining everything.
No, you don't have to explain everything like I'm doing in the video. All you have to do is tell the person your name, your title, call them by their name, wash my hands, I'm going to get your blood pressure. So just tell them the procedure you're doing. Yeah. Mm-hmm. But you don't have to walk through everything and tell them. You're just going to, but now you're just going to tell them, I'm going to get your blood pressure. You also need to tell them, like when you're helping them ambulate or helping them get up out of the bed, that does say you have to instruct them on what the cue is going to be. So you're going to say, I need you to put your hands on the bed. On the count of 3, you're going to stand. 1, 2, 3, stand. So if it says in your manual that you have to instruct your person to do something to help you, you do that. But you don't have to tell them what you're doing with the procedure. You want to keep them informed, but you don't need to tell them how to do the procedure. All right, the next is height and weight. You do not have to do height for national testing, but we do have to do height on every new admission. Okay. Resident height is measured on admission. They don't go by what the resident says. They do shrink over time and get shorter because the cartilage in your bones gets thinner and you start to get shorter as you get older. So don't go by what's on the driver's license because they don't measure you when you go get your driver's license. They just go by your word, right? You're going to measure the person on the stand-up scale if they are ambulatory, and we'll go in there and practice with that. But when you raise it up, you put the little flapper on their head, and then you read it in the center of the bar, and that'll be your test question. When you're doing an ambulatory or stand-up person, raise it up, put it perpendicular on their head, and then it's like a 90-degree angle with the little flapper flat on their head, and you read it in the center of the bar, and it'll tell you how many inches or how many centimeters, depending on what your facility uses. Your weight is the most accurate indicator of your nutritional status. Everybody gets a weight on admission, and that's what they initially base all of their medications on. So we need to get this accurate weight. Make sure your person has gone to the restroom and emptied their bladder. Make sure you're weighing them at the same time of day every time you need to weigh them to help with the fluctuations. If you get up and weigh yourself in the morning and then you go back home and weigh yourself that night, you may be 2 or 3 pounds heavier. Either way. Okay. You have to zero the scale before you get the person up and over to the scale. So the first thing you're going to do when you walk in the room is know how to zero your scale, turn it on, set it to 0, and then the person can walk to it. You're walking beside them, slightly behind them, standing next to them as they stand up on the scale. And then also make sure you're helping them get off the scale so they don't trip and fall and land on the floor. You don't have to put a gait belt on to walk them to the scale. And in facilities, a lot of times you're going to have a scale that has wheels. You just wheel it into their room and you have them set it in place, zero it, and have them stand up on the scale. We're going to learn how to do the manual scales with the little weights that go across, and you'll see that in the video. But the best thing for weighing people is trending their weights at the same time every day.
Accurate measurement and recording of weight is an important responsibility that you must take very seriously. The resident's physician will determine medication dosage based on weight. Weight can also be an indicator of the resident's nutritional status. Perform your beginning procedure actions, which include gathering the following supplies: a standing scale, paper towel, notepad, and pen. First, we will cover the steps for weighing a resident using a standing scale. Balance the scale. Place a paper towel on the platform of the scale. Assist the resident to remove his or her shoes and stand on the platform of the scale. Do not allow the resident to hold onto the scale. Adjust the weights on the scale until the balance bar hangs freely halfway between the upper and lower bar guides. Add the weight on the 2 bars to determine the resident's weight. Make a mental note of the reading. For example, one bar reads 100 and the other reads 39 for a total of 139 pounds. Assist the resident to turn around on the platform to face you and face away from the scale. Raise the height bar until it is level with the top of the resident's head. Record the measurement in the center of the height bar. Help the resident down from the scale. Give assistance to the resident to replace his or her shoes if assistance is needed. Remove and discard the paper towel from the scale. Perform your procedure completion actions. The standing scale should be used for residents who are able to stand on his or her own. Always balance the scale before each use. A chair scale is used for residents who can transfer but are unable to stand long enough for a standing weight. To weigh a resident using a chair scale, follow these steps after performing your beginning procedure actions. First, balance the scale. Assist the resident to transfer from wheelchair to the chair scale. The wheels of the wheelchair must be locked and the footrests raised before the resident is assisted to the chair scale. Place the resident's feet on the footrest of the scale. Move the weights until the balance bar hangs freely. If you are using an electronic scale, read the electronic display. Make a note of the reading. Make sure the footrests are raised and the brakes on the wheelchair are locked. Assist the resident back into his or her wheelchair. Lower the first footrest and assist resident to place foot on it. Repeat for the second footrest. Remember to use a chair scale for residents who can transfer but are unable to stand long enough for a standing weight. Always be sure to balance the scale before use. Place an empty wheelchair on the scale and record the weight. Take the wheelchair to the resident's room and assist him or her to transfer into it. Begin by locking the brake and raising the footrests before the resident sits in the chair. Lower one footrest and assist the resident to place foot on the rest. Repeat for the second footrest. Have the resident move his or her hips as far back in the wheelchair as possible. Reverse these steps when the resident is ready to get out of the wheelchair. Take the resident to the scale. Roll the wheelchair up the ramp and lock the brakes. Adjust the weights until the balance bar hangs freely on the end. Note this reading on your notepad. Unlock the wheelchair brakes and slowly guide the chair down the ramp. Return the resident to his or her room and assist the resident in transferring out of the wheelchair. Begin by locking the brake and lowering the footrests. Lower one footrest and help the resident to place his or her foot on the floor. Repeat for the second footrest. Assist resident out of the wheelchair. Subtract the weight of the empty wheelchair from the weight of the resident in the wheelchair and record this number. This is the resident's weight. As with any procedure you do, perform procedure completion actions. This method is used for residents who are wheelchair bound, for whom transfers are difficult. You must know the weight of the resident's empty wheelchair. Always balance the scale before each use. Now we will discuss measuring residents who are unable to stand. As part of your beginning procedure actions, gather the following supplies: pencil, tape measure, notepad and pen, sheet, and back blanket. Position the resident in the supine position. Straighten the resident's arms and legs. Remove the pillow and straighten and tighten the bottom sheet. Make a tiny mark on the sheet with the pencil at the level of the resident's head. Replace the pillow. Make a tiny mark on the sheet with the pencil at the level of the resident's heels. Turn the resident on his or her side so the marks on the sheet are visible. If the resident is able, assist him or her out of the bed. With the tape measure, measure the distance between the two pencil marks and record this number. After positioning the resident in a position of comfort, perform procedure completion actions. Remember, this method is used for residents who are bedfast or who cannot stand to have height measured. Make sure the sheet under the resident is straight to ensure an accurate measurement. A bed scale is used for residents who cannot stand and cannot sit in a wheelchair. Before weighing the resident using this method, perform your beginning procedure actions. To accurately balance the scale, do so with the canvas sheet, chains, or straps attached. Remove the sling and position the resident on it. Connect the straps and elevate the lift above the level of the bed. Raise the sling so the resident's body and the sling hang freely over the bed. Adjust the weights until the balance bar hangs freely on the end. If you are using an electric scale, read the electronic display. Write this number down on your notepad. Lower the resident onto the bed and remove the sling. After the resident is comfortably settled in bed, perform the rest of your procedure completion actions. The bed scale is used for bedfast residents. Make sure the sling and resident's body are lifted completely free from the bed before recording the weight. Always remember to balance the scale before use. Remember, when measuring and recording vital signs, height, and weight, accuracy is critically important, just as it is in all nursing assistant duties. Your attention to detail will help ensure that proper dosages of medications are calculated and that residents receive the best possible care.
All right, so for national testing, this is how you are going to measure weight.
Come in. Hello, Mr. Mills. My name is Tanya. I'm your CNA today. We need to get your weight. For this scale, I'm going to go ahead and get my equipment ready. I'm going to zero my scale. We're bringing you over and move this table out so that I'm able to stand next to the scale. You can sit up on the side of the desk. Wash your hands and check your bed. We're going to walk to our ambulatory client. So I'm just going to stand beside you and I would zero the scale out here before letting you stand on the scale. So, your shoes on for safety. We're going to move the bottom until the weight comes, the bar comes down and touches the bottom. Bottom weight back to 200. The top bar has increments. Does not touch the top or the bottom here. Doesn't have to be exactly in the middle as long as it's not touching. Okay, and then we're going to add the two weights together. You would step back down off the scale. I'm going to stand beside you to make sure you're keeping it off appropriately, and we'll go back to the bed. And reach. Thank you. I'm going to wash my hands and record. For this scale, we're going to make sure that we put the unit of measurement. Thank you. Have a nice day.
Super nice, huh?
Any questions about things?
So once you take them back to bed, you have to do the.
Just hand them their call bell.
You don't have to wait to get lay down.
No, they can get back in bed. They're ambulatory. They can get up as long as they have their shoes on. You don't have to put a gait belt on them. You don't have to help them get up. You just tell them to get up and we're going to walk to the scale as long as you're standing beside them when they get on and off the scale. So move that little table out of your way so you're able to stand next to them to get on and off the scale. All right, so conversion-wise, like I said, the only conversion that you need to know how to do is that 1 ounce is equal to 30 milliliters, and that 1 cc and 1 milliliter are equal to the same. So you can write cc's or milliliters depending on where you work, but just highlight the one that says 1 ounce is 30 milliliters. When we measure things or when you get a Coke to drink, they give you a 12-ounce Coke. You have to know to multiply that 12 by 30 to write down how many milliliters or cc's they actually drink. On your graduated cylinder that you took home in your buckets, you have one side says ounces, one side says milliliters or cc's. We always measure it in milliliters or cc's. So you don't put how many ounces, either for output or for input. They want the milliliters. Okay, but you don't need to know how to convert pounds to kilograms or Celsius to Fahrenheit. There are charts for those that you can do. Okay. But this is how you do them if you need to. Normal temperature, 98.6 is 37 degrees Celsius. Hypothermia is less than 95.0 with low body temperature. Hyperthermia is anything above 102.2. Okay, so if you have an adult Honestly, even at 100.4, if you get anything higher than that, people are sick. Okay? They start feeling bad, they start sweating. 100.4 is kind of the cutoff to where you need to be monitoring them and watching them. But definitely 102.2 is a seizure risk. They could start going into seizures after they get past that. The last vital sign is called pain management. So for pain management, if anybody says they are in pain, you report it to the nurse immediately. Doesn't matter what kind of pain they say. If they say pain, report it to the nurse immediately. Don't tell them, oh, you just ate, maybe you have indigestion, just lay down and it'll go away. Yes, you want to help comfort them. You want them to stop what they're doing, lay down, feel better, but you need to let the nurse know that they complained of pain. Even if they have arthritis pain and their joints are red or swollen or inflamed and it's acute pain from a chronic condition, you still are going to let us know. Okay? Make sure that you have them sit or lie down, stay comfortable, and I'm going to go tell your nurse. We are not worried about them becoming addicted to pain medicine. They have pain medicine ordered PRN as needed. When they're in pain, it makes them grumpy, it makes their quality of life poor, it makes them sick. So we need to keep people out of pain as much as possible. If they have chronic pains or even acute pains and they have something ordered for it, we need to get it to them as soon as we can. If you wait to take pain medicine until after the pain is worse, it takes more pain medicine to make the pain go away. Okay, so on a scale from 1 to 10, what is your pain? And they tell you it's a 3, you still let us know so we can give them some Tylenol. If we don't give them Tylenol and then the pain continues and continues, by 2 or 3 hours later, this pain is now up to a 6 or 7, now they may need some oxycodone or hydrocodones to get the pain back down. Whereas before, maybe we could have given them some Tylenol or Motrin and they would have been fine. This is what the pain scale looks like. They have a little faces pain scale. If you can't get them to give you a number, just tell you how they look on. Is it unable to do most of their activities because of pain? Are they unable to do all of their activities because of pain? Is the pain interfering with their quality of life? And then let us know. Listen carefully to what they say with their nonverbal cues as well, because sometimes people have cultural differences where they think that pain is a sign of weakness and they don't want to tell you they're in pain. But if anybody is crying or grasping or grimacing, like we talked about in the communication chapter, silent communication is sometimes the most powerful. So when you're moving someone and they guard their arm or they hold their arm, then you're going to ask them, does your arm hurt? Is there something wrong with your arm? And then kind of engage them in letting you know that there's something wrong with them. If they're grunting or groaning or they're irritable or they're quiet, a lot of times people have a migraine or a headache. They don't want noises. They don't like lights. They have photophobia. They want to be in the dark and left alone. So if that's going on, you need to let someone know. Sometimes when people in pain, they just get restless or agitated or irritable. And then we need to know about it. Screaming, definitely. Any speech changes in appetite, dizziness, nausea. Sometimes when women are having heart attacks, they think it's just indigestion or just upset stomach or just nausea, but they're actually having a heart attack. Their blood pressure is going to be elevated. A lot of times, even if people are comatose, we can tell if they're in pain because their vital signs start to go up or start to elevate. They get higher blood pressure, they get higher pulse rates, they get higher respiration rates because they're in pain. So if you notice that those are getting abnormal, then we're going to ask them about pain. Any redness to the area. If pain is left untreated, it can cause horrible problems with your immune system, your nervous system. The resident is not happy, they can't get comfortable, they can't get to sleep. It gives them just a poor quality of life that can lead to depression and anxiety and hopelessness and helplessness and distress. So we don't want people to fear telling you that they're in pain. So when they tell you they're in pain, you take it seriously and give them some empathy and tell them you'll let the nurse know. Now, you are not allowed to give pain medicine, but you can let the nurse know and we will give them their pain medicine. And we are not worried about them being addicted to these pain medicines. Let's see. The most common side effects of pain medicine is constipation. Pain medicine slows you down. It slows down everything, including your bowels. So when we give people too much pain medicine, or they're constantly getting pain medicine, they could get constipated. So these are the people we're going to watch more closely to make sure they're having the bowel movement at least every 3 days. If they don't, they're going to get some suppositories and enemas. So you need to make sure you get them up. When you're getting them up, they may be dizzy or drowsy from their pain medicine. So they become a safety hazard or a fall risk. So we know we've given them some pain medicine. It may make you drowsy. When you buy the medicine over the counter, there's a warning on it that says may make you drowsy. Don't operate heavy machinery. Don't drive a car. Some people take pain medicine, especially like Motrins or non-steroidal anti-inflammatories, and it upsets their stomach. So we give it to them with some food or a snack or something so that they don't get nausea or vomiting from it. Sleeplessness is that they're sleeping too much. Or sleeplessness is opposite than they're sleeping too much. Okay? Sleeplessness means they can't go to sleep. Sleeping too much is the common side effect of pain medicine. Okay? A rash, sometimes people are allergic to their pain medicines, so they'll get a little rash on them, but let us know. There are some non-drug therapies for pain. If we are going to use heat or cold applications, you have to have a doctor's order for that. There's also some people get massage, some people do acupuncture, but all of that has to be ordered by a physician. Generalized entire body, you can do some pain management strategies or cognitive behavioral therapy where you're trying to distract them from their pain, get them thinking about something else so they're not worried about the pain as much. Have them have some humor or some relaxation or some guided imagery. Tell them to close their eyes and feel like they're at a beach and they can feel the waves and the sun, and then it'll just distract them. It won't make the pain go away, but it won't let them focus so much on what's hurting. My dad used to joke all the time with my son when he said something hurt, and he said he'd cut off his toe and then that wouldn't hurt again. Or if he'd distracted because his toe would hurt more. But some people use pet therapy for pain management. Now they have pet therapy dogs that are even emotional dogs. Like you can get your dog as an emotional, registered for an emotional therapy. But they are, like, they've had lots of studies that say petting a dog or petting a pet lowers your blood pressure. So it could lower your pain levels as well. But if you have the hot applications, the doctor has to be ordered. Know that you are not allowed to use a heating pad. They can't plug something in and turn it on because that's going to burn them. They can only use moist heat or dry heat. They have to put a washcloth in the microwave and warm it up a little bit. Leave it on for 5 to 15 minutes. By then, it's cooled itself down anyhow. But you cannot have a plug-in heating pad. Some people have these socks filled with rice, and you just put it in the microwave for 30 seconds and it warms it up for them. Make sure it's not too hot when you touch it. It has to be less than 106 degrees. But warm it up in the microwave for like 20 or 30 seconds and then give it to them, and they can have it for about 15 minutes. Heat really helps with muscle aches and muscle pains. Cold really helps with nerve pain. So if you have a pinched nerve in your back and you're having sciatica or pain running down your legs, you may put an ice pack on your back. If you have a pulled muscle, you may put a heat pack on it. Okay. But it just reduces the swelling, helps with muscle spasms, relaxes things. Moist heat means that the water is actually contacting your skin. Sometimes after people have had surgeries, in their perineal area, they have a sitz bath. If a woman has had a baby and has an episiotomy, or if people have hemorrhoids or hemorrhoid surgery, they sit in this sitz bath that just runs warm water over the area and then drains off into the toilet. Some people have tubs that they just sit in a warm tub bath, and that helps with pain. Moist compresses and soaks. Dry heat is when the water is not actually touching your skin, so it could be inside of a water bottle or wrapped in a plastic towel, but you're not actually having that water touch your skin. They do make these aquathermal pads that plug in and warm water runs inside the pad and heats up the pad. Those are things that you can use with the doctor's order. but you are not allowed to use the dry electric heating pad. And that's in nursing homes, assisted livings, at home health. Elderly people really should not use those heating pads because they never turn off. And they will give them 2nd and 3rd degree burns. Okay, they really only need the heat for like 15 minutes and then that's it. But you'll find people who fall asleep on their heating pad and then come in because they're burned from their heating pad. Cold applications is the same thing. Still need a doctor's order. It's left on for 15 minutes at the most, but every 5 minutes you need to check and make sure that you're not giving them frostbite, that their skin isn't freezing. Has anybody ever put an ice pack on yourself and like left it there for 5 minutes? You're freezing. You want to remove it. You don't want to just leave it in place the whole time. Cyanosis, we already talked about, is the bluish tint. That's a sign of frostbite. Cold applications are good for the first 24 hours when you first have an injury. So immediately when you get a bump or a bruise. We had a patient who the shower head fell and hit her in the forehead. The swelling doesn't get worse till 24 to 78 hours. But immediately when it happens, that first 24 hours, if you just keep an ice pack on it, it will help reduce the amount of swelling in the long run. Okay. When you sprain your ankle, you put an ice pack on it. Okay, so an initial bruise or injury for the first 24 hours, try to put an ice pack to constrict it and keep it from swelling up too much. And then other cold applications have the same thing with the moist cold. It means that the water or alcohol or some liquid is directly contacting your skin. We used to do these for babies and give them alcohol baths. When they got a real high fever, you take off all their clothes and just bathe them with alcohol. When the alcohol evaporates, it cools your skin. Okay. A cold compress, like a wet washcloth. Put it on their forehead, and when you take it off, it's going to evaporate and cools them down. The same thing with that's why we sweat, so that the sweat can cool your internal body. When people have a fever, they are supposed to be uncovered. When people have a fever, they get chills, and they want to put 1,000,000 blankets on them, and they want to turn the heat up to 90. It's not going to help. We have to advise them or try to keep them uncovered. Let the surface area of their skin get to the air so that they can cool down internally. And it's really hard to convince someone who is freezing and having chills to take their blankets off. Yeah, but covering yourself up is going to make your fever worse. It's going to trap the heat in, and then if you're going to overheat. And when you overheat, you run the risk of having seizures. When men overheat, they run the risk of sterility. Like it can actually kill their sperm and things like that. That's why when you have really young boys, you don't want them to be bundled up and hot all the time, because then they may be sterile. Your cold applications, again, with your dry cold, is going to be something inside an ice pack. Does anybody still have one of these little ice packs that you unscrew the lid and put the ice cubes inside? I don't think they even make them anymore. We used to have one when we were little, and you just unscrewed it and stuck the ice cubes inside. Well, just know that you have to have some kind of barrier between you and the ice cubes. So even if you put them in a plastic Ziploc bag, you still need to put a towel or a washcloth or something around it before you put it on their skin. Okay. Unless you have one of these commercially made kind of cloth bags that carry the ice cubes, and then you can just put it down there. Now they make those little freezable things like you put in your lunch boxes, or little boo-boo bears. Those you can put on them. But you really need to put those in a washcloth too, because those are frozen pieces of plastic. Okay. Promoting good comfort and sleep. Make sure the temperature is good. Make sure people have all the blankets that they need to sleep at night. Sleep is extremely important for healing and for comfort, and they have to have a good sleep environment. So limit the amount of noise. If you work on night shift, make sure you're turning off the lights. Pay attention to odors in the hallways that may keep people from sleeping. You don't want to do excessive amounts of cleaning and have bleach smelling everywhere, and they can't sleep because they smell all these cleaners. And they usually wax the floors at like 4 a.m. in the morning. I have no idea why. But the smell from the wax wakes people up, you know? So just be a little bit cautious about people are trying to sleep. Even though you're there working, they still need a good sleep cycle to have good healing and good comfort in periods during the day that they're allowed to rest. Even if you're working night shift, though, you still need to check on your people every 2 hours to make sure they're still in their bed and they're still breathing.